Good afternoon, everybody. It's been almost more than 2 years now since we as a community were actively grappling with COVID. So the daily number of active cases have gone down, restrictions are not as strict anymore, and we are almost back to normalcy in our lives. But most of us are still experiencing some or the other form of post-COVID issues, especially in our where our health is concerned. In RRI itself, I know a lot of the students, including me, have experienced sudden onset of allergies, and we are really struggling with that. So, with all this in view, RRI has launched a new series of health talks called Namma Arogya, and we are here today for the first talk in this series. I invite Dr. Sundri, who is a consulting medical officer at RRI, to introduce our speaker for today.
Good afternoon, all of you. I think I'm not a new person to most of you, at least. For the last 4 years, I've been here in Raman Institute. As Sebanti said, we had COVID time, we had a lot of problems we had, and few really anxious moments also we have gone through COVID time. A lot of students and a lot of our staff were infected. In fact, India has had about 4 crores and 54,000 and odd infected people. In that, 5 lakh lives were lost all over India. I think, unfortunately, from our institute, we had lost one of our own from our own Raman family. So that was the impact of COVID all of us have got. As Sebanti said, we are almost back to normal. We don't think of COVID, no way. No, please, this opportunity I take to again caution all of you that COVID is slowly creeping back. And today's cases, in India, in Bangalore itself, 1,950 cases we have in Bangalore, and 2 deaths day before yesterday recorded in Bangalore. So again, slowly we may have to be back to our precautions about the COVID. Having said that, now, this infection, as you see now, third wave, second wave, everything is over. We were hoping that we are okay, but sometime we were predicting 4th wave. It has not come, so we really got relaxed, and then we said that we are really lucky. But again, it is coming up. This is the peculiarity of this COVID infection compared to any of the other viral infections. It leaves a dent in the health of a person who has been infected with COVID. It can be any system can get affected, starting from the neurological. People are forgetful, and people are having dementias, and people have a lot of psychological stress after the COVID. Same thing, other systems like GI system and respiratory system. Most common system which gets affected is the respiratory system, which leaves a long time suffering for the people, as Sebanti was mentioning. So this is named as post-COVID or a long COVID, it is called. That means it has got a lot of respiratory symptoms, maybe cough, maybe breathlessness, maybe the activity performance has come down. So we have a lot of questions about it and a lot of doubts about it. To clear all the doubts and then to make us a little more aware of this post-COVID problems, we have among us today Dr. Prasanna Kumar, who is a pulmonologist by profession, and he is associate professor in Ramaiah Medical College and Hospitals. And he is, apart from dealing with all the respiratory problems, his special interest is mainly a COVID, post-COVID. I think Sachin has got a very right person, thanks to Shubha and her team, to select Dr. Prasanna Kumar to talk on this topic to us today. Now, Dr. Prasanna Kumar is specialized in other things apart from the routine, and he is specialized in sleep breathing abnormalities and post-COVID and other things. And he is specially trained in interventional pulmonology, that is bronchoscopy and pleuroscopy interventions also. And in academic front, he has got a lot of publications to his credit, both national and international. About all this, I want to say, I'm very proud to say that he was our student in Ramaiah, number 1. Number 2, I want to say, when I asked for his CV, this is the 4 words he has given to us. That shows his simplicity. And he is a very approachable and a very simple person and very caring to the patients. And here I present Dr. Prasanna Kumar for you, to this august guardians, to give his lecture. Dr. Prasanna, please.
Thank you, ma'am. Thank you for that kind words. I'm really honored that my teacher is giving me the introduction for a talk here. Thank you, everyone. Good afternoon, everyone, to all the distinguished audience here. I thank the Raman Research Institute for giving me an opportunity to deliver a talk here on the topic of my interest, COVID-19. So before COVID, it was more of pulmonology was not so much spoken about. Nobody knew who was pulmonologist. After COVID, with the COVID, I don't know, it would have done a lot of damage to people around. For pulmonologists, at least, it is given a little bit of recognition here. And I feel honored to be here in the Raman Research Institute. And I want to say that, like ma'am said about long COVID, it is the name for post-COVID and whatever is happening after the COVID infection. The present knowledge we have is as the fist of the hand, and what has to be learnt about it is as vast as the earth. So I would like to start with my talk with this statement. So I bring greetings from Ramaiah. So this is Ramaiah Medical College, Ramaiah Medical College Hospital and Ramaiah Memorial Hospital I work with. I'm here for more than almost 10 years now, and I was a student even before that with madam way back in 2000 to 2006. So a scope of today's talk, I just give a brief introduction on what is actually long COVID is, and the sequelae, what is to be considered now, and brief discussion on what has been learned now about pulmonary and even the extrapulmonary. Extrapulmonary, I meant to say everything other than the lung is extrapulmonary. And when are we when we are looking up about the sequelae, how often are we following up, and how is the care given based on the follow-up, the post-COVID care? There are certain preventive measures, new normal, I should say, like madam was telling, no, we should not be relaxed saying that COVID is gone. So there is something called as new normal that we have to practice from now on, and that is new normal as a very, very simple measures or preventive measures that we can follow. So that is what I'll just highlight on, the concept of post-COVID rehabilitation. Talking about infection, it is an acute infective stage. Everybody would have gone through. It was a respiratory infection. Saying that the virus, the portal of entry was the respiratory tract. Okay. Once it enters the respiratory tract, it causes a respiratory infection. Then post-infection, there is a post-infectious inflammation, and the post-infectious inflammation becomes more systemic. It goes beyond the lung and does all the damage. So therefore, the rehabilitation when it is, I said when it goes beyond the lung, it can go to any distant organs. So madam was mentioning about the brain, where the neurological manifestations are being seen, to extent of musculoskeletal system, okay, which is way beyond, way away from the lung. So these things of post-COVID rehabilitation, so that is the most important thing, more than giving any kind of medications, tablets. Someone who's having allergy post-COVID, maybe there would be some viral infection would have triggered the underlying allergy, but the rehabilitation is the actual part of the care in the post-COVID. Prevention of complications, when we see something like COVID in the patients in an acute infective state where there's a patient is infected, we would like to do certain things so that we prevent the complications which happens during and after the breakthrough infection, okay, after the long COVID, that is after that days or weeks or months after the COVID infection. So that is about the prevention of complications. And who actually, after saying all these things, I have to say that I must say it is the recovery team, it is a holistic approach, where it is not only the pulmonologist, or it is not only the physician, or not only a cardiologist or neurologist. It is a holistic approach where everybody as a team should work on it for taking care of the COVID-19 recovery. So this term has caught attention worldwide because I just started my talk talking about this. What has been learnt about it is only as a fist of the hand, and what has to be learnt is as vast as the earth. So only a small knowledge about long COVID is, it is the state where you are not recovering several weeks or months following the starting of symptoms. That is suggestive of COVID, whether you are tested or not. It means to say all those patients who are not tested positive, or those who are even the symptom suggestive of COVID, we did say of syndromic approach in an era where after the first wave, we were seeing many negative testing, RT-PCR negative. So therefore, we have to look up the patient as a syndromic approach, where the patient is having symptoms suggestive of COVID, and therefore we say whether you are tested positive or not, or you have symptoms suggestive of COVID. So this is about the introduction of COVID. So I must emphasize on this slide that you can see what all things can go wrong in the body, whether it is in an initial infection, the actual cause of deaths in post-mortem studies in the first waves way back in outside overseas, they were saying it is post-mortem studies showing there are blood clots in the lung. So that is a pulmonary embolism. Okay, so because of blood clots, there was cardiac arrest. Okay, there was low oxygen saturation, hypoxia, causing cardiac arrest. So there was some heart rate irregularities because cardiac muscle also being involved in COVID, causing a heart failure. So these are, stroke was also one of the first manifestation when the patient was presenting in the emergency, where patient would come as a stroke, okay, where there was a blood clot in the brain. So again, there is a clot in somewhere, okay, whether it is micro, small clots or large clots extending either in the brain or the heart or in the lung. So that was about the initial infection. That was what we used to see. That was a spectrum of things we used to see. In the long COVID, it was more of things which we will discuss in further slides, and it is because of some amount of dysregulation in the autonomous activity. So there is some system in the body where it is regulated according to the normalcy. Okay, if there is some dysregulation, that is when you experience all that what you experience in the long COVID. So that is because of this dysregulation. And MECF is more of a chronic fatigue syndrome, which is actually the actual thing which we will be talking about it later. And breakthrough infections, all these other manifestations can also be a possibilities during the COVID and even the post-COVID or long COVID patient. Okay. So after recovery from COVID, so patient remains at risk of developing anything like whether it is lung disease, heart disease, frailty, that is mental health disorders, many things. So these are the common things that has been noted, and these data on long-term effects are still emerging. So we still know very less about it, and the presumed sequelae of this disease is resemble those that we have already experienced earlier. Whatever that SARS-CoV-1 in 2003 and MERS, that Middle East Respiratory Syndrome in 2012. So these were the virus which were very similar to the COVID-19 virus, and whatever the sequel we saw, we have experienced it, which is very also shares the same similarities. So that is how we have presumed that the sequel is more or less the same thing. And I said there is very limited data about it, limited peer-reviewed data focused on the prevalence of the long-term sequelae. So pulmonary, cardiovascular, neurological, and it is even the beyond pulmonary. I said extra pulmonary. It is because of some receptors where the virus used to bind and do all the job, where it is the receptors are present everywhere across extrapulmonary tissues. And among these patients of the SARS-CoV-1 in 2003 or it is 2012 MERS. So what was I observed was the lung capacity was low and exercise capacity was coming down at the end of 6 months following discharge, and there was post-traumatic stress disorder that was noted. Depression and anxiety were still the things that was noted in those viral infections, those days in previous infections. But now that we practice evidence-based medicine, we are looking for the same data that is being seen in this COVID, post-COVID, where there is retrospective studies with confirmed patients who are discharged in, this is from the New York City hospitals, where it says that, many of the patients, they sought emergency care even after discharge, within median 4.5 days of the thing, and they required inpatient readmission. And one of these patients who were returning to the readmissions were experiencing the respiratory distress. That was the actual experience we are seeing. So compared with the patients who are not returning for care, for example, someone who is not returning for things, if they are returning for something else, so it would be something like COPD, there is a pre-existing lung disease. Like I said, there is a pre-existing lung disease. The virus can trigger and can accentuate the symptoms, causing exacerbations, and even the hypertension. The blood pressure was also shooting up in those patients who have been experiencing this infection. So the hospital stay was somewhere between 5 to 7 days. Experiences from Italy. So if you see that mean hospital stay was nearly 14 days. We know that in Italy the mortality was huge compared to all over the world, and they assessed based on the questionnaire that nearly 32% of the patient had at least one or two persistent symptoms in the follow-up period. 55% had more than 3 symptoms. I'm telling about all these symptoms over here. So starting from fatigue, dyspnea is a shortness of breath, joint pains, chest pain, cough, anosmia is a loss of smell. I'm sure we all of us who are like infected will experience that loss of smell and loss of taste. So then the dysphagia is the altered taste. Headache is the other one which was very much a problem, troublesome, where we were working about the black fungus those days, but the mucormycosis, it was actually named as wrongly named as black fungus, and the other things like vertigo and the GI symptoms, the diarrhea, vomiting and things. So 44% of the patients, they reported to be having the very poor quality of life. Okay, then again from the US again, the data is based on the age, based on the comorbid conditions. It means the patient as the increasing age at the more severity of developing the severe COVID, and once you have a severe COVID, therefore your possibility of you ending up with a long COVID sequelae are high. At the same time, if you have a more number of medical conditions, like you have a diabetes, you have hypertension, you have kidney disease, heart disease. So when the number of medical conditions increases, therefore the number of the possibility of you going in for long COVID sequelae are more. And also on the individual medical conditions like obesity. So most of the deaths we noticed in the first wave in Ramaiah was obesity. So the patient in the afternoon was so fine, doing good. By evening he's gone. That was because more or less we are looking at it, the obesity was one of the medical conditions where causing the progression to severe disease was very rapid. Now this is the recent study where Indian study is saying that what are the symptoms that we are experiencing or noticing even now. Okay, so there are data which started from 2020 when the COVID started, and the extrapolation of data since then has been slowly becoming more and more finer, and now there are so many symptoms that have been removed from the sequelae that has been noted. Okay, there are few symptoms which has been published as the long COVID sequelae were not seen in the recent studies. It means to say that we are the research methodology and the number of sampling and the way we are doing the research among the long cohort of studies. So where it is showing off that more symptoms was the fatigue. Fatigue was the most common symptom that is seen as a sequelae. So the chronic fatigue syndrome is what I was talking earlier. So you can see this. This is the symptoms from 6 weeks to 3 months. I can show you this. Fatigue is the one. Next is the breathlessness on exertion. Okay, then the muscle pain or muscle aches. Okay, so those are the other things with very less about headache, tinnitus, vertigo, rotation. So those are the other things that was noted now recently in this recent study by India. The same study when they noticed the persistence beyond 3 months. Again, the fatigue is the common symptom. Fatigue is a common symptom. Though the breathlessness or exertion has come down. If you see this, previously it was 37%. So now it has come down. So it means beyond 3 months, so all those respiratory symptoms are also waxing off. So all the respiratory symptoms are also waning off until you have something pre-existing lung condition, like madam was telling that the allergy is booming up. Okay, we have seen many patients where they started having many respiratory issues because maybe they had an underlying respiratory morbidity when this virus acted as a trigger, and therefore now you're seeing the sequelae of lung disease. But this slide emphasizes telling that the chronic or the long sequel of COVID is more of fatigue and other system other than lung, though lung is also involved in few subset of patients. There are few subset of patients have gone all the way to lung transplant also. Okay, so but there is very less. So if you see the numbers, it is like coming down slowly. Okay, when you go, this is beyond 3 months. So when you see a cohort of more than 6 months or 1 year, the number has again come down. So the prevalence of cough has come down 0%, which was actually a symptom earlier, which was actually we were seeing in the first wave and second wave. So the post-COVID cough used to last for more than 2-3 months or 4 months. Okay, treating a post-COVID, now any post-viral cough by that matter, it may last for longer time. So that is what we have seen here. So with all this knowledge, there are gaps because of deficiencies in methodology, the way we interpret the limitation, the results, and extrapolation. We have some experience on MERS and SARS with fibrotic sequelae. What is this fibrotic sequelae? It means fibrotic nothing but the lung is big, the spongy lung is becoming more and more smaller and smaller. The lung capacity is getting very low. It is reducing so much that your exercise capacity and your symptoms of breathlessness and exhaustion, what I showed earlier, it is been there even in the MERS and SARS, and that is also been shown up here. Unlike you have to rule out the other fibrotic lung diseases. So now identifying the phenotype, which is the actual type of patients likely to show resolution is still a debatable. Okay, so now moving on to cardiorespiratory sequelae. What is that we experience? I showed you what is the evidence already existing. So cardiorespiratory, it is the breathing. So breathing, again there is a confounding where breathing discomfort or exertional breathlessness or breathing difficulty on exertion can be because of some physiological impairment also. There is an actual lung injury which is causing the lung damage and lung function decline. There is dysfunctional breathing for other reasons I told you about, some regulation, autonomous regulation that is happening. And there is other coexisting things like, whether the heart is also involved, where heart and lung both work together. Both they are, they work together, and when there is a potential heart failure, when the heart is not adequately pumping, and because of the myocarditis symptoms, it means the muscle of the heart, the cardiac muscle, there is inflamed. So when there is inflamed cardiac muscle is not able to do its relevant duty, and it is failing, it has a potential to go for a heart failure. That is when you can have breathing difficulty. It may not be only because the lung issues. Okay, so these are the possible issues where breathing difficulty can be because of residual cough. I just mentioned about it. Yeah, there are patients who had residual cough even beyond 3 months, even beyond 6 months. So probably we may have to look for other causes for this residual cough, or maybe there will be some amount of lung injury that has been triggered, causing fibrosis of the lung. The fibrotic lung definitely has some dry hacking cough, and residual cough be there for a long time. Thrombosis, micro or macro, whether it is thrombosis, nothing but the blood clots. Blood clots can exist even in the acute infection or even in the post long COVID sequelae beyond 3 weeks. So the blood clots can be there because of the exercise limitation. The patient is not moving around. So the blood clots, the possibility of immobility can trigger the blood clots. So this thrombosis of micro blood clots, micro or macro, with small blood clots, very much smaller in size, which may not do any symptoms, not manifest with any symptoms. Macro, which can cause very troublesome symptoms like heart failure, even cardiac deaths. Someone who has gone through the ventilator, severe COVID disease, who has gone for oxygen support, high flow oxygen, or even way beyond the ventilators, so they may end up with tracheostomy, where we want to bridge the ventilation by doing a tracheostomy. You make a small hole in the trachea, and the patient starts breathing through the tracheostomy. Here, by doing that, you are actually reducing the work of breathing, and you can have a good airway control when the patient is on long-term ventilation on the ventilatory support. So those things are possible things which can be seen in the long-term sequelae. If at all the patient has gone through tracheostomy, then the tracheostomy-related injury, granulation, some wound healing problems. There is the stoma of the tracheostomy, which may become smaller, and that can also cause difficulty in breathing in later stages. Okay, glottic injury, again the vocal cords, and dysphonia, that are all the other possibilities that can happen. And extreme fatigue, like I mentioned, extreme fatigue is the only thing that is noticed, that is been published in literature as of now, as the only symptom which can last beyond even 6 months. COVID. So during COVID, what was the only drug that was very helpful for the human life is the steroids. Okay, other than remdesivir, the antiviral, which came later, part of the in the first wave, the steroid was the one which saved many lives. Whatever the number of deaths Madam was explaining about, 5 lakh, why it was only 5 lakh? Why not more than that? Because it was steroids. So it was the steroids which did a lot of relief, where the steroid, when it was also used it was a double-edged sword, where it was also irrationally used in some outreach, in peripheral sites, where they had very resource limited settings, where they irrationally used steroids, which also causes some side effects of long-term high-dose steroids. One of those side effects everyone experienced was the mucormycosis, the black fungus. So that was also because of the irrational use of steroids. So infection status, we have seen patients having positive status even at the end of 1.5 month. So the patient is positive now. We say the viremic phase lasts for only 7 to 9 days. The maximum is like week time, or at the most 10 days. So where we have seen people, when they have some experiencing symptoms, and when you get repeated test, the tests were positive throughout even after the end of 1 month, 45 days. So that was again because of the continued viral shedding, and therefore there was about the news about the recurrence. So it was all about the first and second one. Then we learnt about it. What is it? So this was about the previous one, and the viral shedding, they have shown in the research that it was seen even at the end of 70 days as well. So that was about the other things that can happen for the long-term sequelae. Yes. Moving towards the other systems like neurological, where I said the viral post-viral inflammation, which can also cause heightened risk of ICU, acquiring when the patient is just having a severe disease and patient is there in ICU for a longer time, okay, with so much of sedations or injections. So the patient is more, when the patient is bedridden for longer time, he or she is more for developing the ICU acquired weakness. We call it as critically illness polyneuropathy. So I have seen my own colleague of mine, whose mother was infected, and went through all this ventilator support, tracheostomy, and finally landed up with critical illness polyneuropathy. She could not move, and it took a longer time, more than 3 months, for us to bring her back to normal. Now she is walking around. And this is the heightened risk of ICU, where the larger the length of stay of an ICU, the severe the disease, and it also reflecting that the more severe the sequelae are. And prolonged recumbency, again, the exercise limitation, breathlessness on exertion, fatigue. So all these things increases because of the severity of the disease. Some paresthesias were also experienced by a few patients. There was the tingling and numbness sensation, that is what been expressed. Strokes, I told you, the presentation only was sometimes was a stroke, okay, because of blood clots in the brain. So strokes, anosmia and dysgeusia, altered smell or no smell, altered taste or no smell, everybody would have experienced. And this is no smell or anosmia or altered taste or dysgeusia is what we call, was noted only not beyond 10 days of time. So even the research says that beyond 10 days, more than 70 to 80% of the patient would get back their smell, sensation of smell, and would get back their sensation of taste. So that was about anosmia and dysgeusia. Extreme fatigue is again the same thing that we have been talking about. Other system involvement, where during the acute stage of COVID, there was some reported cases of kidney injury, but over a period of time, requiring some dialysis at that time, but they were recovering at the same time. Skin and soft tissues, patient is on prolonged recumbency, not moving around. Madam was talking about allergy, where urticaria, the boggy swellings because of allergy. Again, it is because of the virus and post-viral inflammation that has triggered the immune, and this immune response is causing something called as urticaria. So these boggy swellings. So this skin manifestations of urticaria was the common thing that was noted post-COVID for a longer period of time, beyond 3 months as well. And other than urticaria, what was seen in the skin was the hair loss. Hair loss is another one because of the extreme stress. Okay, extreme stress that is going, the body is going through the insult. So there was a lot of hair fall at the end of 3 months, and the patient continued to have hair fall beyond 3 months as well. So soft tissue, ECMO specific issues. ECMO, you know, it's an artificial lung. So it's an extracorporeal membrane oxygenator where it acts like an artificial lung, like how we have a dialysis machine for a kidney renal replacement therapy. Like that we have ECMO. So someone who's having completely diseased lung, where the lung is not actually doing the actual job of ventilation. Okay, that is the actual job, transfer of gases, oxygen and carbon dioxide. Inhale oxygen, exhale the carbon dioxide. So then the patient are more put on the ECMO, and when the patient are put on ECMO, the catheters are deployed in somewhere inside the larger blood vessels. So because of those things, these sutures and the catheters were deployed in the groin sides, in the neck sides. So these sutures were also had some sequelae, and that has been noted earlier. Sexual health, so again the stress itself, to say the insult to the body in all types, the autonomous dysregulation, there is the autonomic activity, the autonomic activity is being completely dysregulated, and that can also cause some amount of erectile dysfunction and impotence that has been noted in the few subset of patients. Moving to the pulmonary perspective, I said pulmonary perspective beyond 6 months is very low, attributing, though the breathlessness or exertion still remains the same problem, though there are few subset of patients will have cough, residual cough for a longer time, but pulmonary sequelae is very low. These are all the research. I'm talking about the data, what is available. So there was a lot of lung damage that was shown, okay, and this is about the data earlier, and the blood clots. That is also, because of the blood clots that was observed in patients, which showed that there was evident lung damage, and therefore the patients were dying of lung disease or severe COVID pneumonias. So the actual underlying cause was the blood clots there, and the post-viral inflammation that is causing the damage inside the lung. So approximately this thing I think I have already mentioned. So who are the persons who are going to long COVID sequelae? I had mentioned in the previous data I mentioned, where the advanced age, the more the age, the more severe the disease. So the less the immunity is what I can say. The immunity passport, I should use the word immunity passport, as even though you are being on the hybrid immunity, where you have been actively infected and also passively immunized. So you are in a hybrid immunity, you are carrying an hybrid immunity with you. The immunity passport, though it is been there with across all the age groups, the advanced age still carries a risk of long COVID sequelae. And I said the longer the length of ICU stay, the higher the severe the disease, the patient on mechanical ventilator, the more the chances of developing the long COVID sequelae. The other things like smoking, COPD patients who are smokers, who had a pre-existing lung disease of chronic obstructive pulmonary disease, or say smokers, asthmatics who are smokers. So they were the patients who had some remodeling in the airway defense in the lungs, and therefore they are more prone for severe disease, and therefore with severe disease you go for a long-term sequelae. Not to forget the chronic alcoholism itself, alcohol consumption itself can cause decreased immunity in all possible ways, and this decreased immunity can trigger and provocate the severe infection and severe inflammation. Again, there is a data about other things which are not been spoken about in the slides, where there was patients who had experienced, even there was a faculty, in the medical fraternity, there were pulmonologists who had experienced the femoral head necrosis. Okay, they had exposed to the COVID so much, and they did not manifest with any of the symptoms. They ended up with only one of the symptoms, like femoral head necrosis. It means the head of the femur, there's a long bone in your thigh bone. Okay, the head of the femur, it gets necrosed. So the support, it loses the support. So because of large dose of steroid pulse therapy. Okay, that is also one of the complications. So if you say any patient who is going for large dose of steroid pulse therapy, they are prone for this femoral head necrosis. Okay, so these are the other things. This again about lung function. Some data is telling that at the end of 6 weeks of infection, at the end of 12 weeks of infection, how is the lung function measured? Okay, lung function is measured by doing a simple spirometry. Simple spirometry measures the lung function where the patient is asked to do some forced expiratory maneuvers. The forced expiratory maneuvers, when it is done for few seconds, say for example 5 to 6 seconds, we measure the lung function, the lung capacity by seeing the forced expiratory volume at first second. Okay, so that is the actual lung function we measure for all the asthmatics, for COPD patients who are smokers, or all the lung disease, anyone who is having a chronic lung disease. So this is the actual lung function we measure, and this FVC, the forced vital capacity of the lung and the forced expiratory volume, at the end of 6 weeks, you see there's 23% decline, 28% decline. At the end of 12 weeks, still there is, you can still notice that there are decline in lung function is still noticed, but slowly it is getting better. But the diffusion capacity of lungs, this is another test, high-end test. It's an advanced pulmonary function test where we look up to the tracer gas, carbon monoxide, which is when inhaled by the patient. Okay, when it diffuses across the lungs to the blood and comes back, we measure, that's called as carbon diffusion lung coefficient of carbon monoxide. This is the DLCO, and this is the actual measure of the lung ventilation. Okay, all those patients who actually acquire the viral infection causing interstitial or lung damage or alveolar damage, like I mentioned earlier. So if there is an alveolar damage or there is an interstitial damage, the DLCO measures the actual lung function, and then you can see that this DLCO has shown also there's a decline in DLCO and in measurement in patients who have also gone through severe disease. Some CT scan findings, this is all medical terms where there's so many signs. I can just show you how it was looking like. So it was seen even beyond 3 months. So there was repeatedly when the patient developed some amount of even a trivial symptom, patient was asked to get a repeated CT scans. Okay, and these repeated CT scans showed these patterns. Okay, there's a crazy pavement, the pavement, like our flooring. So it looks like a crazy pavement pattern. So there is some airway, stretching of the airway walls. You can see holes like thing. So traction bronchiectasis we call it as. So some bands, the bands like lines here. So the bands and some ground glass like appearance. Ground glass like appearance. That is the persistent ground glass appearance. So these are the patterns we saw, which was noted even beyond 3 months. And we said this is the persistent radiological signs also that was seen. And not to worry, because even in the SARS-CoV-1 and even the MERS, also when they did a 15-year follow-up, they did notice that these things disappeared over a period of time. Okay, there was no residual damage. Only were a very few subset of patients who required extensive treatment of even going up to lung transplant. They did have some remnant residual patterns of damage that is seen even beyond 10 years. But very beyond the study of 15 years, it says that these patterns which are seen, which are also, they're all disappeared. Okay. What is the treatment for this lung disease, if at all, if it has affected the lung and if it has gone to the stage where it has gone for pulmonary fibrosis? So what is the treatment? It is more of a supportive care predominantly. Though we have few things on the dashboard, that antifibrotic therapies, where other fibrotic lung diseases were treated with antifibrotics, were also tried with these COVID patients. Okay. Even me myself, I have tried in our post-COVID patients where we have given up to 1 year of the antifibrotics, up to 1 year. And beyond 1 year, we noticed, we heard, we read the research which was blooming up saying that it is whether you give antifibrotic or not, the patient is going to recover. Okay, unless the patient is very much progressive. If the patient is progressive from day 1 to at the end of day 6 months also, then you should be more cautious in treating by giving other antifibrotics as well, even adding on some treatments. But for someone who is stable, there is no need of looking up the CT scan and starting on antifibrotic therapies, unless the patient is very much symptomatic. So these are the drugs that are available, antifibrotics. It is given in interstitial lung disease. The interstitium of the lung is affected in the COVID, and therefore it is treated like interstitial lung disease. These antifibrotics, nintedanib and pirfenidone, both are of same activity, and both are of can be given to interstitial lung disease. Role of steroids, I was mentioning it earlier, it was irrationally used. We were also used in the first wave. We didn't know that, how long to give a steroid, when to stop it. Though there were consensus of statement across India, across the world, by experts talking about stopping the blood thinners for the anticoagulants who had blood clots in the body, whether it is lung, heart, or in the brain. When to stop it, or when we start steroids, when do you want to stop it? So still there is absence of robust data, and if you want to treat it, probably in the initial stages, when there is worsening symptoms, when there is oxygen support is required, when the ventilator support is required, definitely the corticosteroids act as a potent anti-inflammatory in dealing with this hyper-inflammatory syndrome. So these are so many drugs are in pipeline in the research for treating this interstitial lung disease as an anti-fibrotic agents. But what we have is only the nintedanib and pirfenidone, which has already been prescribed. Moving on to the most interesting slide, the extrapulmonary sequelae. I must say, more than pulmonary, it is the extrapulmonary sequelae is what is being seen even beyond 6 months. So this is how the manifestation is. You can see starting from the neurological, what is the common thing, frequent thing that is seen is the headache. Headache is the frequent thing. Okay, some other things like Guillain-Barré syndrome, they call it as some kind of ascending myelitis, where the patient experiences some weakness of the body, both upper limbs and lower limbs. Slowly it can affect the respiratory pump, the respiratory muscles as well, and that is though reported, but is very rare. And other things what are common in neurological manifestations are headaches, myalgias. I'll be talking about the post-exertional myalgia, where the patient little exertion gets getting up from the chair. Also the patient experiences some kind of weakness. The muscle strength is low. So that is the myalgia thing, that is a very common thing that is seen. Thromboembolism, it's again saying that the blood clot in one place, it is circulating to other place. The thrombus, it is going to other place, the thromboembolism. It is going to the veins in the legs, that is a deep vein thrombosis. It can go to the lungs, the pulmonary embolism. It can go to the other parts of the body, so the catheter related thrombosis. Liver, hepatic, what has been noted was only the liver enzymes were altered for a brief time. But with the recovery, even that got better. Okay. And kidney, I just mentioned about that. There was some acute kidney injury during the course of time of infection. That was only in the active stage. And post-active infection, so the renal function used to come back to normal. So gastrointestinal, nausea, vomiting, diarrhea were very frequently seen during the course of time. Even in the recent third wave, most of the patients presented with nausea, vomiting and diarrhea, not with fever, cold, cough, like we noticed it earlier. Okay, the variants, once the variant has changed, the manifestation also has changed. The most frequent symptoms in the third wave was gastrointestinal. Okay, where most of the patients had loose stools, most of the patients had vomiting along with the fever. Okay, these are the common things. Endocrine, we are giving either it is the stress-induced hyperglycemia where the sugars used to shoot up, or it is because of the steroids we were giving during the course of illness, which was actually causing the high sugars. So that is again causing hyperglycemia and the other serious form of diabetic ketoacidosis. Cardiac, I told you the cardiac muscle is involved, it is inflamed, it can cause myocarditis, it can cause heart rate variabilities, arrhythmias, it can cause heart failures, it can cause shock, heart attacks. So all these things were seen. Everything was seen. Even the heart rate irregularities were also frequently seen. There is something else called as postural orthostatic tachycardia syndrome, which I will be telling about it. Again, that was been there for longer time. Even the patient has recovered from COVID for way beyond more than a month or 45 days. There is the heart rate is still showing 120, 130 heart rate in a resting person, not in a person who is an active person, not an exertion. So this postural orthostatic tachycardia syndrome was also seen. So that was also seen very much frequently in the post-COVID symptom. Dermatological, I have told you, the urticaria and the hair loss being the most common thing, which will be seen as a long-term sequelae. Active times in the active infection, there was erythematous rash, there were some other lesions because of bleeding manifestations. So those things are very, very less. So what we used to do when they had cardiovascular sequelae, we used to get a cardiac MRI done, again to look up for the myocardial inflammation. Okay, again it is reflecting on what is the activity in the myocardium, whether it is actually the cause of reduced left ventricular fraction, whether the heart functioning is low, or whether it is also increasing, showing the volumes in the chambers, cardiac chambers. So in all the controls and also test patients. So this is what the terminology I was talking about, postural orthostatic tachycardia syndrome, where it was reported in so many case series where you are even beyond 3 months after the acute phase of COVID. It means that if while you are on rest, okay, there is heart rate is very high, or heart rate is very much normal. While you get up from the sitting posture, okay, there is an increase in heart rate for up to 20 to 30 beats per minute. Even standing for 10 minutes, okay, this heart rate changes. So this was because of the posture. That is called as postural orthostatic. You change the position from sitting to standing, and therefore the tachycardia, the heart rate is high. So the real clinical burden is still unclear. We are still doing a lot of studies. There are many studies being done for this tachycardia syndrome, where they are doing many cardiac MRIs in all the patients who have been experiencing the same. So these are the long list of things that can happen because for the heart, even after recovery. That is the heart, whether it is ischemic, non-ischemic, there is some heart failure. This is the heart rate variability, sudden cardiac, causing risk of sudden cardiac deaths, and the same. And it's all because of the pro-inflammatory state. So the cytokine storm is what was spoken about. The second week of COVID illness, where you anticipate the cytokine storm. That is when the patient will go back to ICU. That is when the patient was very much fine in the active viral disease the first week. The second week he or she develops pneumonia or any other manifestation, and that is mostly because of this cytokine storm, and this is because of the immune activity. The immune system, it reacts more than normal, and therefore it is called as hyperinflammation state. It's called as hyperinflammation state. So we do a lot of measuring the cardiac enzymes. We look for whether it is elevated, not elevated. You do a imaging, you do a ECG, echocardiogram. Okay, we want to MRI scan. We want to see what is the cardiac activity is. So this is how we do assessment and monitoring. Neurological sequelae, I mentioned it's more of neurocognitive impairment. That is what was seen in even after resolution, typically within 3 months. What is the acute thing was this one, which loss of smell we were seeing, that is anosmia. The myalgia, the muscle pains, or myositis, stroke I have mentioned. There were patients who had also showed presented with seizures, that's the fits, and the nerve diseases. What was post-viral, what was seen is the Guillain-Barré I mentioned earlier, the weakness, and this is the multi-system inflammatory syndrome, which is commonly seen in children's in the COVID and post-COVID. We've not been talking about children's all this time, okay, because the children's are less likely to develop the post-COVID sequelae, or even at the most active COVID things, where we notice we have seen only very few children going through the morbidity or mortality for many other contributing factors. But this Kawasaki disease, which is the multi-system inflammatory syndrome, which was noticed mostly in children, and it was more of neurological manifestations. So this was seen in children more than adults. So again, it is all because of the hyperinflation. So anywhere from the pulmonary, it can cause direct invasion to the nervous system. It can post-infectious because it can trigger the immune system and do all the damage of affecting the brain cells and other manifestations. So when do you want to follow up? Now we know that these are all the manifestations that patient can experience. So you want to follow it when? So I said long COVID is from the starting of symptoms till the weeks and months. So ideally it is 6 weeks where we say it is the patient is going for resolution. Beyond 6 weeks it will be more of post-COVID. And I must say it is only after 3 weeks you say it has a long COVID or post-COVID. Beyond 3 weeks, 3 months. Okay, that is after 12 weeks. This is from the British Thoracic Society guidance, where they said at the end of 12 weeks after discharge, you have to assess the patient with for all this COVID sequelae, post-COVID sequelae. You do the X-ray, you do a clinical assessment, you do the lung function test. If you think there is a blood clots in the lung, and if the patient had already experienced a blood clots, then you have to assess the oxygen saturation. You do some sputum sampling if the lung parenchyma is affected. You do a ECG or echo. You do a lung cardiac assessment. So all these things you should do for every patient, because you never know. We have seen so many reported deaths in the post-COVID era. Okay, we don't know who is going to have what sequelae. Okay, though the risk factors of only people who are having severe disease, though people who are having one or more medical conditions, though who are having elderly people, more age, advanced age, less immunity, immunocompromised, though many things have been spoken about immunocompromised status, but we don't know. So therefore it is mandatory. It is said that 12 weeks after discharge, if you think the patient has experienced a severe or moderate or severe COVID, you must assess the patient for all these things. If there is something seen, you need to consider referring to the specialist and for further care. If there is a cardiology issues, cardiac involvement, send it to a cardiologist. If there is a lung issue, send it to a pulmonologist. So if there is a neurological issue, send it to a neurologist. So that is about the referral. That is about the follow-up. So respiratory per se, we used to do a X-ray, virtual clinic. We used to follow those. Now with the hybrid era, hybrid immunity, there is a digital era also. So the virtual clinics have set up because of COVID, and these virtual clinics, we used to pre-order chest X-ray, and before the patient comes back to us, so we see the X-ray then, and if this is normal, you don't have to do anything. So you see something existing in the chest X-ray, you need to do a further assessment by doing a lung function test. You want to do a CT pulmonary angio to look for blood clots in the lung, and you want to repeat the X-ray if at all the patient is having some patches. And if there is something like interstitial lung disease, you do a high resolution computed tomography, HRCT, CT scan of the chest. So that is what we do. And you have to also consider something called as walk test. We used to very religiously do walk test. What is 6-minute walk test or incremental shuttle walk test? I'm sure you all would have played the musical chair. Okay, so this incremental shuttle walk test is very similar to that, where there are 2 points which been put across, and you have to walk around the place, and that distance has been measured, and every time the distance increases. That is what we call it as incremental shuttle walk test. Okay, that is one thing that is done in the setting of rehabilitation center. But 6-minute walk test can be done in any corridors, where you are asked, when you know the distance, that this distance is 10 meters. So you ask the patient to walk for 6 minutes. Okay, then there you are measuring the exercise capacity. You are also measuring the oxygen saturation. You are seeing the heart rate. Okay, all these things you are monitoring by doing a simple 6-minute walk test. You don't have to do a lung function. You don't have to do a CT scan for you to assess the exercise capacity or the functional status of the patient. So this, considering the walk test was done very religiously in a post-COVID clinic. And yeah, on those patients who are severe patients who required oxygen support during the acute infection, we want to follow by doing repeated echocardiograph. We want to see how is the heart functioning. So they again to see the peripheral and lung disease, vascular disease. If there is any existing peripheral vascular disease, like any vascular vessels, blood vessels have been involved in the legs, in the extremities, so you need to refer to the vascular surgeons and specialists. So what has to be very simple preventive measures that we have to practice as the new normal. Okay. So we know that prevention is better than cure. It has been said during our schooling as well, where we say that rather going through all these things, the best strategy is to prevent before you go into post-COVID syndrome. So how do you do that? You do a very simple things. You taking up the offers of COVID-19 vaccines. You're masking up, I am sure today also I have just removed my mask. So though it is like, we are trying to relax ourselves, the masking should become the new norm and everybody should practice the same, at least when you are in a crowded place, when you are in a gathering. Okay, hand hygiene became another new norm when no one knew about what exactly hand hygiene is. I must say even the persons who are working in the hospital setting, they also didn't never used to not practice that hand hygiene techniques. When that became very regular, they became hand hygiene became one of another new norm where along with the fitted masks and your patients who are coughing and sneezing, you let them know about the etiquette, so how they have to follow, and you ensure the indoor spaces are well ventilated. Even if there are patients of active COVID infection in this hall, if this room is well ventilated with cross ventilation, it is very less likely for any of us to acquire the infection. That is what I meant to say about ensuring indoor spaces are well ventilated. So what else we can do at home? We can do a self-monitoring. So this is now become another tool at home, okay, another gadget at home. Now everybody at home has one pulse oximeter. Earlier only the doctors used to carry this, or the nursing staff. And self-monitoring the blood pressure, oxygen saturation, and pulse rate and temperature, it should be made mandatory. And when you experience some symptoms of any illness for that matter. Diet. So we are exposed to so much of for us, for the medical fraternity, for us as a frontline warrior, as doctors, healthcare professionals, high protein, other than you are going through a PPE, a personal protective equipment, where you are trying to cover up yourself, which is not giving any kind of warranty. Okay, though the personal protective equipment is completely covered your body, so the other way of you protecting yourself is your nutritional status, that can also build up your immunity. So protein meal, okay, that should be monitored, and aim to have at least this the few vegetables which are very important for us to keep up our healthy lifestyle. Proper sleep hygiene. How is like sleep is an indirect way of hurting, troubling our health. Is if you see that if anybody is having a high blood pressure or uncontrolled sugars, I must say that you should look for your sleeping habit. You should look for your sleep hygiene. So for sure there would be some contribution by the sleep itself, which causing you having this uncontrolled blood pressure or uncontrolled blood sugars. Okay, so sleep hygiene is so important for our healthy lifestyle. Okay, the sleep hygiene, and I must say you have to quit alcohol and quit smoking. For all it can cause of damage, and simple analgesia before you attend the specialist, that can also be taken care, but with caution. So now moving to actual thing that is been there as a post-COVID sequelae, it is the fatigue, the chronic fatigue syndrome. How do you manage that? I was talking about the post-exertional symptom exacerbation, PESEG, or otherwise we call it as a post-exertional malaise. It is a weakness you feel. You feel like the muscles are becoming sore. You're feeling very weak, little exertion. So this was actually also a feature of COVID-19, and it was noted way beyond 6 weeks to up to 3 months. Okay, this was characterized by disabling fatigue on exertion. There was some difficulty thinking, pain, some exercise intolerance. I'm not able to. Earlier I used to walk up to that. Now I'm not able to go up to that height. So this is that exercise intolerance, all made worse by exertion. This exertion not only mean the physical exertion, but also the cognitive stress, the thought process. Okay, even it is affecting the thought process. The cognitive stress is also affected, and also the emotional stress. These symptoms can occur immediately, just within 24 to 72 hours, or even it can last beyond the prescribed time, and it is very subjective to the patient. So it is both of subjective. How you are understanding your energy levels? Say for example, you have imagine you had 10 bags of beans to fuel your day. So when you are feeling well, it may feel like getting up from bed uses only half of bag. Okay, but when you are actually recovering from the COVID, so it means you need to take you need more than 4 bags. This is a simple way to make you understand that what the fatigue actually means. Okay, So you need more energy, for doing even a minimal activity. So how do you go about this? So we do a relaxation techniques. You control your anxiety, you improve the quality of life, and reduce pain and discomfort by doing minimal exercises. Social life, we are now slowly going back to social life. All those patients who have gone through serious COVID illness should slowly distract themselves getting into social life, getting some good emotional impact also by doing so, by meeting others. Also, those who are also already experiencing the COVID sequelae. So there is some subjective assessment where each patient is assessed appropriately and will be prescribed a graded exercise. It means not every patient will be giving the same exercise. Okay, there will be a graded exercise where some patients may require the small steps, and some patient may require the higher steps of exercise therapy. So that is a graded exercise which will be structured according to the patient, and it is very individualized. It can be titrated and to the activity of the patient based on the level of fatigue. So how we do that? So we are doing this by the concept of rehabilitation. So rehab is there everywhere. Now it's a neurological rehab, there is cardiac rehab, there is pulmonary rehab, so psychological rehab. So it's all things about rehabilitation. What it means? It actually confirms that in any chronic diseases, this improves the exercise capacity, whether it is breathlessness, anxiety, depression, fatigue, and even the thought process, the cognitive stress, even that can be tackled with this rehabilitation. So not that rehabilitation can tackle everything. You can see there is pulmonary rehabilitation can tackle few things like fatigue, muscle weakness, breathlessness, exercise tolerance, cough, okay, to some extent depression and anxiety. But other things like sleep disturbances, hair loss may not happen with this rehabilitation. That is what is the challenges. Few things need a different structured strategy. And who needs this rehabilitation? Rehabilitation is for those who had a prolonged hospital stay, who was in ICU, who was with ventilator support, who required some amount of supports, whether a patient experienced pneumonia or had other symptoms lasting for a long time, and where the clinical judgment was prolonged. Who cannot be enrolled in the pulmonary rehabilitation? Someone who is having an extensive neurological manifestation, extensive heart disease, someone who is having heart failure, you cannot tell him to go and do exercise. No, it will worsen it. So same thing like renal, when the patient has gone through some trauma, polytrauma, and other body system involvement, stroke, it will be like a phased manner, it will be graded. So these patients will not be sent for rehab earlier, and there's a long list of patients who cannot be sent for rehabilitation. So how do you prevent the complications now that you have some COVID and COVID-like sequelae? So you can prevent the fibrosis of the lung by timely giving some steroids which can act as a potent anti-inflammatory and anti-inflammation, and this anti-inflammation can delay or even delay the progression to fibrotic stage, or even it can halt the progression to fibrotic stage. Thrombotic sequelae, blood clotting mechanisms, again prophylactic anticoagulations. Even before you think that the patient would have experienced, we think that this patient is at high risk of developing blood clots. So someone who is not moving around, who is having severe disease, we prophylactically start them on preventive measures as some blood thinners. So that is starting them on prophylactic anticoagulants. Respiratory muscle weakness can be dealt by starting up with chest physiotherapy as early as possible, as the patient just goes through the active viremic phase. Okay, at the end of 1 week, the patient is good to go for a physiotherapy. Okay, as early you do the physiotherapy, so the better the patient becomes, and the less likely the patient goes for a long-term sequelae. There are patients who are requiring long-term oxygen therapy even now, even after a year time. Okay, they are on oxygen. Okay, there are very few patients, not to say that, like I mentioned, like other symptomatology which was seen more frequently in individuals, but patients who are having lung damage, requiring oxygen support, very few subset of patients, and there are still patients, whenever it is indicated, you have to give them oxygen therapy. Long-term oxygen therapy, it means the patient is on oxygen for more than 18 to 20 hours a day, in 24 hours. Okay, that is what it means, long-term oxygen therapy. Vaccination, so all these patients should be given a vaccine shot, whether it is flu, whether it is pneumococcal vaccine. Again, for the reason they are prone for viral infection, they are prone for all kinds of hyperinflammation state that they have experienced all this while, and therefore it is better you give them a flu shot or pneumococcal shot, so that even if they acquire an infection, the severity of infection is brought down by giving vaccine shots every year. That is the annual plan. And diet and nutrition, I have already mentioned. The high protein diet and some fruits of importance can be considered. These are an example for education program for post COVID-19 rehabilitation. Okay, so for respiratory, you manage breathlessness, cough. Again, it's more of musculoskeletal issues, and some information if the patient is on tracheostomy care. This is all I'm talking to about at the end of the talk, where I'm summarizing it. Fatigue management, you should look for sleep hygiene first before you say it. The fatigue is because of the post-COVID sequelae. So you look for the sleep hygiene. You pace the strategies of your, whatever the rehabilitation program you've done, and some energy conservation wherever it is required. You are asked the patient to do that, and you gradually resume the activities. Patient who was running earlier, now after post-COVID, who was to play I had patients who used to play badminton. So after the COVID, they stopped doing it. So I had to push them to get back to activities as early as possible. But because of this fatigue, even beyond 6 months, it was difficult for them to get back to that normal activities. Psychological care, again, it's very important. You're managing the anxiety and depression, and the patients who are on long-term ICU stay, patients who are on ventilator, patients who are on sedations because of ventilation and ICU stay, they were more prone for developing delirium. So they used to get dissociated with the surrounding. It's called as delirious state. So the information on delirium should be known, and these are the patients who used to go for delirium, and we should manage them accordingly. I said the post-traumatic stress disorder, which was also seen in previous viral infections like SARS-CoV-1 in 2003 and MERS in 2012, where they had many patients who are reported to have post-traumatic stress disorder. It means that even after this trauma they have gone through, okay, this stress lasts longer than usual. So muscle deconditioning done by the strength training, pain management, activities of daily living, neuropathies and ulcerations, other things can be managed accordingly from the neurologist. Nutritional management, you give education on diet enrichment. Smell and taste retraining, someone who's having this issue in the acute stage, they can also be spoken about. Speech, someone who's gone for long-term ventilatory support, so swallowing retraining, voice control, and these tracheostomy patients, they would have lost all these things. So these are the patients who require this speech and communication, where the swallowing training and the voice control, cognition, speech, everything is being given. Returning to work, returning to driving, returning to relationships, returning from the social isolation or loneliness, all these things are also a part of the post-COVID rehabilitation. The who all can join hands to become a recovery team. So it is the physiotherapists at the most. Now because we talk about the chronic fatigue syndrome, where the rehabilitation is more at the front line than giving any medications, whether it is a neuro rehabilitation or psychological rehabilitation. The physiotherapist is the first one. Occupational therapist, again, if the pulmonologist is involved, looking for the lung, the cardiologist for the heart, so on and so forth. And a counselor or psychologist or psychiatrist is very much because of the anxiety, depression, and suicidal tendencies have also been reported in many patients who are having a long COVID symptoms. These are the extended services for many other disciplines in the post-COVID sequelae. So to conclude, the fatigue, headache, and attention disorder, hair loss, and breathing difficulty or breathlessness on exertion appear to be the most frequent symptoms. Severity is what it reflects on the post-COVID sequelae. If the severe the disease, COVID disease, the most likely to become going for a long COVID sequelae. Increasing age and more number of medical conditions are the potential factors that can go for long term. And post-COVID is usually self-resolving, but it compromises the quality of life and the daily activities for several weeks. And long-term follow-up studies are still needed, and I said it is still that we are still learning what are the evolution and possible intervention can be done to treat or reduce the post-COVID symptoms. We not lose hope. All it takes is that one bloom of hope to make a spiritual garden. Thank you. Thank you for a patient listening. We'll be happy to take questions. That is me myself, that PP. I wanted to put it, say, we have gone from that era to this era now. Okay. Thank you.
We can take some questions.
Almost all of us have gone through the COVID troublesome period, and we have all recovered. Some people may have noticed some symptoms of it. Whether you attribute it to COVID or not, it is left to the doctor. But for a normal person, do you have any recommendation to see the residual effect in your body so that it can be diagnosed even though it has not come to the surface? What is your recommendation? Like, for example, periodical screening of our body to know any forthcoming disorders, malfunctions of our body can be known well in advance by screening it. Is there anything like that for COVID, even though you don't see it at the moment?
So thank you, sir. That was a nice question. So like I said that not everybody experiences the sequels or consequences, and only those who have experienced the severe COVID patients with elderly, advanced age and with other immunodeficiencies, only those experience. But coming back to your question of screening to even any normal person. So we say that anyone after 40 years of age, this has become a new norm now, where we have to screen every year for your heart and lung, especially the heart. Okay, where you get a screening of your cardiac CT coronary angiogram to see your calcium scoring, to see what is your risk factors of developing a cardiac disease, which is ultimately the norm. The only thing that has been reported in the recent times, where we have reported deaths of many youngsters in 20s and 30s in the post-COVID, when they had no symptoms, when they had no sequels. Okay, probably it's again very unfortunate that they being many doctors itself, so they being medicos, so they could not appreciate anything, or maybe they would have ignored as something subclinical symptom that was there that they were experiencing. They ignored it as very trivial symptom. And no, for everyone who have experienced COVID now, since I mentioned it, I've been stressing on that it is very important to emphasize that after COVID, anyone for that matter, we don't know, we are still learning. Who will go in for complications is really is very is debatable. So no, we don't know. Like sir said, no, and screening above 40 years of age, it will become a new mandatory. See, earlier all the cardiac diseases was noted only diabetes or hypertension or any cardiovascular diseases was noted only above 50, 60 years of age. Now it is very much normal. You can see it even in 20s and 30 years of age, hypertension. So again, it's all related to the new norms of lifestyle and whatever they're experiencing, they're accustomed to it. But yeah, after 40 years, it is mandatory that you screen yourself every year, at least every year, not once in a year, not very frequently. For someone who is already going through something, someone who's already having a pre-existing cardiac disease, lung disease, so definitely you have to be looking after your doctors, following up with your doctor at least once in 3 months or at least 6 months of time.
So thank you very much for your talk. The question I have is there an Indian data repository where you can get the data on the statistics to build the statistics for the Indian cases that have happened? Because a lot of the data that you showed and a lot of the graphs that you showed were actually based on European data or American data, etc. And I have looked for Indian sources, because it's not that the Italian study is going to be the same as the Indian study. In fact, if you display those long COVID graphs, you will see that they do not correlate very well between the Italian studies and the Indian studies. So the question is, we need to know things for ourselves, and I do not find very good data sets which one can rely on, which are available in the general public domain.
So this is the Indian data. So this is recently published. You can see in 2022.
Yeah, but this is an analysis which has been done.
Yeah.
Where is the raw data?
I didn't get it.
Look, we have had 44 million cases.
Yes.
Where is that data?
Yeah, there is 30,000 publications still on the,
No, but where is the data? The
Data.
publication will analyze
Yes.
the data. Where is the data is the question. Sorry? ICMR. Oh, okay. Have they made it public?
Yes. The data is.
Yeah, please ma'am, please go ahead.
Sorry. Data is not made public, but the analysis has been made and the publications, as Dr. Prasanna said,
Right.
have come. The data, each case is noted, and ICMR knows even now. That's why I could say yesterday in Bangalore how many cases were there, and then 2 days back how much is the jump from day before to today. All this data is there. Raw data is available, but the publications, there are few publications after analyzing all this data, it's coming up. But anyway, Indian, we are slow a little to publish compared to other countries, but this time COVID data, yes, it's very well done.
Okay.
It is very well done.
Oh,
compared to any other disease, COVID very systematically done, very well done.
Okay, thank you. That's
Okay.
good to know.
Yeah, that's the data madam was telling about ICMR. Recently, this director of ICMR, Dr. Bhargav sir was here in the campus in Ramaiah. So he was so hesitant to talk about the raw data like you're asking about post-COVID. When we asked about what is your experience, he's like, we are still waiting to talk about the raw data, which is still there, which is yet to come. But they have it, but they don't want to, voice out about the raw data.
Yeah, but this is actually very troubling, because COVID is, it's a time sensitive thing. I mean, in 5 years' time, when we are ready to publish, it may not be relevant. So then it becomes of quote unquote academic interest. People like us who are academics may still make publications out of it, but when you need to inform yourself in a meaningful way for the next wave, if it happens in 6 months' time, we should have that data available. We should have the data available to analyze and make sense of. Because, for instance, another big problem is the vaccination safety data. It is not available in public domain. And this is again a very serious issue, because all sorts of claims are made, and here we recommend that we do the vaccinations and the boosters. But the question is, what are the safety issues, etc. I mean, these are things which are very actively discussed, but unfortunately we cannot, we are keeping the data to ourselves. And so how do you see the way forward so that things are faster?
Correct. Like sir, you said that even I mentioned about the first wave data and the second wave data, and this is a meta-analysis. What I'm showing here, this is an Indian study which is a meta-analysis actually. It's published recently. So all these things which we are reflecting only on the first and second wave. So there is nothing spoken about the third wave or henceforth whatever we are experiencing now. We call it as fourth wave, fifth wave, because it becomes so sporadic now. It's become like common flu. The COVID has now become like a common flu. It has been there everywhere now. And we are not so vigilant about, like how we used to be earlier in the first and second wave. And this data definitely, it will be of only academic interest later on if we are not producing it at this point of time.
Any other questions?
Thank you very much for this very informative talk. I have a couple of questions.
Yes, sir.
One is regarding, For having good health, one certainly needs to have good immunity. So you have also mentioned that. So in that context, for some cancers, I mean, for these degenerative diseases, immunosuppressants were given as medicines, and that's when COVID struck, and some people had to be, I mean, their medicines had to be stopped to get immunity to prevent COVID if it, and unfortunately, some people actually passed away because of the withdrawal of these medicines. And now we hear about immunotherapy for cancer. So is there a contradiction here? I mean, 3 years back, we were removing immunosuppressants, and now we have new therapies like immunotherapy. Is there a contradiction, or is it something I have wrongly understood? That is one question. Secondly, regarding immunity, now there are claims like, I mean, we have a lot of organic food available in the market now. So some people say that organic food is good for immunity. And I also happened to read a very popular book by a certain Dr. Strand, where he advocates the regular use of nutritional supplements by normal people. I mean, those people who really don't seem to have any diseases or anything. Still, you buy quality nutritional supplements and take them on a regular basis to keep your immunity high. So would like to know your opinion on these matters.
About the balanced diet, whether it is organic, we talk about organic now because of more of adultery is the issue there. And organic, we are trying to say there is no adultery. And anything that is no adultery, which is organic, is definitely healthy. I must say there is a second question. First question, I will say that yes, all those patients who were on immunosuppressives had to be stopped with those brief time, and there were some casualties reported, but that is the actual protocol, where that is the only way where we want to prevent this viral replication, where the patient is already on a immunosuppression and there is a viral load in patients who are already having immunodeficiency. So that might cause all the extent of severity of illness. So that is the only way to withhold for a time. And there were patients who were even with that small brief time of for 5 to 7 days, the phase of viremia, the first week of illness. So that is when we want to stop any immunosuppressives for that matter. We don't even want to give steroids, which is actually doing good, at least in the viremic phase. So yeah, there were casualties, sir. That was very unfortunate, and that is a protocol. And that is the scientific rationale is you want to prevent the fast replication of virus and in the viremic phase, and that's the only way to stop any immunosuppression for that matter.
Thank you.
Thank you.
Doctor, I think you have given a wonderful description of COVID and its side effects.
Thank you.
But now these vaccinations have come out in a very short period of time, and most of us have taken the first, second dose and the booster dose. Do you have any data or saying that what are the side effects of these vaccinations? Because we do have some, I've come across some papers where they say that vaccinations have definitely triggered some autoimmune or some other effects and so on. So do you have any comments on this?
Thank you, madam. That was a wonderful question. So I should have mentioned it also. So I mentioned it for allergy, where I said that someone who's already having a pre-existing atopy or allergy, what we say, with this virus, this triggers and causes more rampant, and it may evolve into a disease state where it may last for longer time. Say for example, someone who never had a reactive airway disease like asthma, after this viral infection started developing asthma. So same thing like for any other autoimmune diseases. Okay, probably there was an indwelling subclinical autoimmune disease that is reported as well. It is not that I am speculating or just saying by presumption. It is reported in a published also that like how a virus can trigger an atopy. Atopy is again nothing but an immune regulation. It is an immune response. Autoimmunity is also an immune response. So even that can trigger, and we have reported cases of developing a full-fledged autoimmune diseases. So yes, vaccines have caused some side effects, adverse effects, serious adverse effects, where the difference is someone who's having only simple pain, swelling, and redness, and that is the adverse effects, and someone who's requiring hospitalization and medical attention is a serious adverse effects, where hospitalization of death also been reported. That could be again because of some trigger of this viral or virus or viral like particles that has been used for in the form of vaccine. So that would also trigger these regulations.
I'm sure there are more questions, but I think we should move on. So before we end the session, Dr. Sundari, can you please present a token of appreciation from our side? On behalf of the director and the institute, I would like to thank you very much for a very interesting talk and a lot of information.